Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
A very warm welcome to Peter's podcast with Dr. Yugal Mishra. To begin with, studies have shown that while minimally invasive cardiac surgery has benefits, it may not be suitable for all patients. How do you address the potential bias in patient selection while evaluating the success rates of mixed versus traditional surgery?
I am Dr. Yugal Mishra, Chief of Clinical Services, Chairman, Manipal Institute of Cardiac Sciences, and Chief Cardiovascular Surgeon, Manipal Hospital, Dwarka, Delhi. I am addressed today about the importance and benefit of minimally invasive cardiac surgery. Since last 50 to 60 years, the cardiac surgery has been practiced as a conventional stenatomy heart surgery. But since the inception of minimally invasive, inception procedures, the approach for cardiac surgery has changed altogether. Now, surgeons worldwide are trying to practice minimally invasive cardiac surgery, whether it's a coronary artery bypass surgery, whether it's a valve surgery, or other problems related to the heart issue. Now, why we are switching over to the minimally invasive surgery? Now, there are certain advantages with this approach, like the blood loss with minimally invasive surgery is much less. We don't cut the bones. Instead, we go between the ribs, either on the right side for valves and congenital defects, or on the left side for coronary artery bypass surgery. The incision is typically either on the 2.5 to 3 inches. With that incision, we could be able to perform open heart surgery or beating heart surgery for coronary artery bypass surgery. Now, besides, either on the blood loss is less. Besides that, we don't cut the bones. There are other advantages over conventional surgery with minimally invasive surgery, like the pain after 5 to 6 days of surgery is much less as compared to the conventional surgery. Cosmetically, this is much superior approach. And of course, the recovery time is very fast. The ICU stays less, and even a total hospital stay is less. So, based on these advantages over the conventional surgery, we started practicing more and more. Now, is each patient is suitable for minimal access surgery? The answer is no. There are certain patients who are fit for minimal invasive surgery, but there are others who are not. Because of the complexity and presence of other comorbidities, like a patient who is a heavy smoker since last 20-30 years. Now, if you have to do the minimal access or robotic heart surgery.
So, my next question to you is, for complex cardiac conditions, how does minimally invasive surgery compare to open heart surgery in terms of effectiveness and safety? Are there any specific scenarios where you would always opt for traditional surgery despite the benefits of mixed?
So, when we discuss about the complex cardiac problems, particularly the problem related with cardiac aneurysm, dissections of aorta, cardiac or diffuse disease, now those are not a candidate where we can practice minimal access surgery. Because we can try to do minimal access surgery, particularly for ascending aorta, that's okay. But if there is involvement of arms, involvement of descending aorta, there is dissections, so those are not patients where we can do minimal access surgery. Hence, the conventional route is definitely the options. Cardiac So, most of the complex surgeries like cardiac LV in the region, cardiac ventricular septal ruptures, patient who has got low ejection fraction, cardiac diffuse disease, or patient who require multiple valve replacement and repair, or aortic surgery are really not a suitable candidate for minimal access cardiac surgery. Instead, we have to practice a conventional surgery.
Carrying forward the conversation, minimally invasive cardiac surgery can be more expensive due to advanced technology and equipment. How do you justify these costs, especially in a country like India, where healthcare affordability is a major concern?
Definitely, the minimal access surgery is more expensive than the conventional surgery because of the fact that we need a lot of equipments, we need expertise. For that, we have to get training. Cardiac patient has to pay 1.5 times more than a conventional surgery. But then there are other advantages which covers this extra payment, like patients don't require extensive ICU stay. Hence, we are gaining on ICU bed charges. Patients can go out of hospital in 5 to 6 days instead of 8 to 10 days as conventional surgery requires. Yes, again, there we are gaining. And most importantly, in 3 weeks' time or 4 weeks' time, patient can start working. So he start earning after 4 weeks instead of sitting for 3 months. So in nutshell, patient is gaining more as compared to the conventional surgery. Though on the start, when they come for surgery, they pay 1.5 times more than conventional surgery. But the total outcome, you see, economically, the conventional surgery is more expensive as compared to the minimal access.
So, we would like to know, when complications arise during a minimally invasive procedure, how do you manage the transition to an open heart surgery? What protocols are in place to ensure patient safety during such a critical switch?
Now, suppose we are doing minimal access surgery and some complication arises. For example, if we are doing minimal invasive coronary artery surgery and patient started having low blood pressure, cardiac or patient fibrillate, then how we manage? In that situation, we have to put the patient on heart-lung machine at the earliest. For that, we use femoral artery and vein. Once we put onto the heart-lung machine, then we can easily manage the case. Suppose this is not possible, then we have to convert the thoracotomy to the sternotomy. And once we convert the sternotomy, then everything is fine. So, cardiac, in situation where some complication arises, we should be ready to tackle that. And that can be tackled either by fem-fem bypass or by converting the incision from sternotomy to midline sternotomy. Sometimes cardiac complication may occur after performing the surgery, like bleeding disorder or bleeding problems. So we can be experienced enough handling that. Another problem which sometimes we face is, like, suppose we are doing bypass surgery in the vessels, coronary arteries are intramyocardial. Searching the vessel becomes sometimes tedious, but as your experience grows, you become well-versed, deal with all these complications. So definitely, there is a possibility that patient may develop some form of complication, but beforehand, preoperatively, we screen the patient and try to avoid the complication than treating the complication.
How do the type and rates of post-operative complications compare between minimally invasive and traditional cardiac surgery? Are there any specific complications more commonly associated with them?
Now, in post-operative period, sometimes patient may also get some form of complication, which is possible both in conventional surgery and in minimal invasive surgery. So there is not too much difference, except sometimes, suppose there is a little bleed and we have not opened the pericardium extensively, so the pericardial blood collection sometimes bothers in minimal access as compared to the conventional surgery. For that, we now started putting two tubes, one in intrapericardially, one in the pleural, and that has taken care of. Sometimes, when we remove the pacing wire which is put intraoperatively, that can bleed. For a midline sterotomy, we can enter and open, and you can stop that. But in minimal access, we have to convert. So that's some of the issues. But otherwise, in nutshell, the complications are both common with minimal and midline or conventional surgery, and both can be. Sometimes femoral artery and vein, which we use for coronary, for the cardiopulmonary bypass time, that sometimes may give some complication, and we have to ready to manage that. So in nutshell, the complications are not very high as compared to the conventional surgery. They are in both approaches, whether it's midline or with the.
Now we would like to know, how have advancement in aortic clamp technology influenced the outcomes and efficiency of MIC?
Now, in minimal access surgery, definitely we require advanced technology and lot of instrumentation. We require a long left-hand instrument, whether it's a pickup, scissors, needle holders. Same way, we also require different kind of cross clamp. Cardiac. In a CVG, we require a partial clamp, and in keyhole, aortic valve or mitral valve surgery, we require a flexible clamp. So, because of the availability of these flexible clamps, our life has become much, much easier, and we could able to perform cardiac access surgery with ease. So, my advice is, whenever you want to start minimal access cardiac surgery, please do have full minimally invasive instrumentation, including a flexible cross clamp or a partial clamp, as we use in coronary artery bypass surgery or in NICAJ or robotic assisted coronary artery bypass.
What specific features or qualities do you look for in an aortic clamp when performing minimally invasive procedures?
Now, the flexible clamp which we require in minimally invasive coronary surgery or valve surgery must be sleek, cardiacally stable when we cross clamp. Because of the fact, suppose during procedure a cross clamp slips, then there is a problem. So there should be stability at the clamp. There should be sleekness so that they can enter through the small port which we utilize for minimal access surgery, and they should be reliable, and if possible, they can be afforded. So some of the features which we have seen recently in a Peter surgical clamp, which is available in India, this is giving a really a good support to the patient, to the surgeons who are doing minimal access.
And finally, we would like to know, from a patient's perspective, how do advanced aortic clamps contribute to reduce recovery times and improve surgical outcome?
Now, if you see in the patient perspective how these advanced flexible clamp give better quality of life or doing surgery. So, if we use a conventional clamp, then we may have to increase the size of incision. With the flexible clamp, the size of incision is smaller. We can introduce these clamps through the port, cardiac, then because these are the flexible clamp, can be applied through the small port and come out and give a bigger working space to the surgeons. So the outcome of surgery is definitely better. So in nutshell, besides other cardiac which are meant for minimal invasive cardiac surgery, flexible cardiac clamp is really very cardio to the surgeon and patient for ease of doing surgery and also for outcome of surgery.
And to close with, what are your views about Signet flexible clamp?
Now in India, the Signet clamp which is available for the surgeons who are practicing for minimal access cardio. So, my practice, I started Signet clamp since long time, and that has given us possibility to use in a small pore and get a better working space compared to the rigid clamp or conventional clamp. Hence, Signet clamp is a bone both for surgeon and for patients for surgical ease and also for better outcome.
Let's meet at EX 2024 in Lisbon on the booth 230 to discover more about surgery, education, and innovation.